Hello, everyone. I hope and the other parts of the room excited for day of the Vein Summit. Having pleasure to someone in life in hope doctors, and so I'm gonna bio. I might add. Oh
no.
Hold on.
Are you there?
Can you hear me now?
Yes, perfect.
Okay. We'll go without the AirPods.
That's so much
really
better.
Great intro for everyone that you couldn't tell by my face. It was amazing. We're going to try again. Welcome back. What I did say was that I really hope that our friends from all over the world are up and ready for this final talk for day 2 of the San Diego Pain Summit. I have the pleasure of introducing Dr. Sandy Hilton, who has changed my life in more than one way, all of them good. And so I'm going to start out by reading her bio, which I may garnish a bit. I was going to say embellish, but that's not the word I'm looking for. I might add a little bit more. So Sandy Hilton teaches health professionals and community education classes on returning to function following back and pelvic pain, and co-teaches advanced level male pelvic floor evaluation and treatment for entropy physiotherapy, as well as neurodynamics and sensory integration for pelvic pain, and a practical application of pain science with pelvic health solutions. So her clinical interest is chronic pain, with a particular interest in complex pelvic pain disorders for men and women. She has co-authored 2 papers, 2 book chapters, and Why Pelvic Pain Hurts as a patient-focused book. She also shared a dream of opening a place where all of these people who have complex pain issues could come to a safe, comfortable place. And she opened up entropy physiotherapy with me and has mentored me and worked with me for the last 7, almost 8 years. Almost 8 years. So it's been really wonderful. And now we get to have a little show and tell with Sandy. What do you have for us?
I have one of my masks from Venice, which you can't see because it's really big. What?
I thought it was a hat at first.
No, it's a mask. And I have to keep it very far away from the cats because they like it a lot. So I brought that because to represent travel and finding cool things all around the world, because I think there is very cool all around the world.
Very cool. And I do believe some of those people are here with us. If not, they're going to be watching the video because I do know it's late for some of them. So with no further ado, we will begin Sandy's presentation, which is called Mind the Gap, What is Happening to Those Taken Off Opioids and Still Having Unrelenting Chronic Pain. So a very important topic, a very timely topic, and we look forward to listening.
Hi, I'm Sandy Hilton, and I am very honored to be able to be speaking for the San Diego Pain Summit for the October 2020 virtual, wonderful, fabulous adaptation of what we're doing with pain care and how to help people. My presentation today is Mind the Gap, Forced Tapers and Unrelenting Pain, where we're going to be having a journey on what happens with the people who are still in pain, even though that they have been taken off their medication. I need to do a little bit of a disclaimer before we get started. You should always understand who the speakers are coming from, and in this particular conversation, I don't have anything that I am bound to tell you. There is no one paying me for this other than speaking for Rajam, but this is more a philosophical journey on how we can help the people who are dealing with unrelenting pain. I need to let you know, I am not a pharmacist. I cannot give you information about which medications are going to work well with other medications, what's the best thing for your patients to be on if they've been taken off their opioids. I'm not a medical doctor. I cannot prescribe medication. I am a physical therapist who works with people who need help with their pain. And I work with people who haven't gotten better. They wouldn't be coming to see me if they were better. So there is a reporting bias to that. The people who are fine with coming off their opioids don't come talk to me. But we need to be aware that some of the people who have been forced off their opioids are not okay. Their pain is not well controlled. And those are the words that they use, that they have been forced off their opioids. It wasn't a choice that they made. It was made for them. Some of these people have plans to end their lives if the pain cannot be controlled. And that is something that we need to be aware of, something we have to keep in mind. I have cried in all of the attempts at recording this, and I'm doing it again already because I know what I'm going to be talking about. So you should grab a tissue. We'll wait. We're going to go, it's not all dark. There is hope. There is a way to help people, but we're going to be talking about people that haven't gotten any better. And I've just decided that I'm going to go ahead and cry if I need to. There's a song. You could play it in the background. It's important to remember that opioids do have their place. And we do have some good evidence that people can be helped with short-term opioids. It's good for acute pain. It can cut down that absolutely unrelenting pain from acute injury. And that should happen for 3 to 5 days. The Brain Man Stops His Opioids video is something that I give to my patients when I'm trying to give them something that they can look at when they start to get discouraged or wonder, where am I going to go with this? It was developed in 2014. So I like to point out that none of this is new. This is, while we are in 2020, people have been dealing with this for a very long time. Some of the research on opioids came out in the last century, 1990s, about the prolonged opioid use can actually sensitize the nervous system and make people worse. So we know that we want to have people in appropriate use of opioids for 3 to 5 days to help them to develop a coping mechanism, to get to move, to get to the ways to get back to their life in a way that is not taken over by unrelenting pain. What we're going to be talking about in this presentation are the people that are in that place in between where they've come off the opioids, but the things that have been proposed to them were insufficient to help them to be out of pain and get back to the things that they're interested in life, or that make their life feel fulfilling. Those are important. Those are important. It's part of what makes a person feel like a person. There is proper limited use. My most recent, perhaps only, use of opioids was when I had a tooth that had had a root canal on it previously, and it was getting infected just over and over again. And we went and we looked at it, and one of the root canals was infected. I went on antibiotics for 2 or 3 different repetitions, and it just didn't get better. It kept getting reinfected. So they tried to revise the root canal, but that didn't work. So I went to an endodontist. You go to your dentist, and then an endodontist, and all up the chain. And eventually we decided the best thing to do would be to pull that tooth and put one of the replacement teeth in, the little peg, because continued infection in your mouth is a very bad idea. It was horrible. The whole procedure was absolutely traumatizing. And I know a little bit about pain, but it doesn't make it not hurt. And so I'm sitting at this surgeon, She did the Novocaine, which I'm one of those people that metabolizes it really quickly, and I told her that and said, can we use Marcaine because that stays a little bit longer? And we did that, but the procedure's pretty intense apparently to pull a tooth. I've never had that done before, and it was not as quick as she thought. So there was this portion of time between when she's trying to pull part of my tooth out that had broken off and so some of it came out, the rest of it was still inside, and she's trying to pull it out, and then all of the pain medication that was there was just gone. It was excruciatingly painful, and I'm just looking at her, and she's looking at me, and she said, I'm just going to finish this. I'm like, okay. And so she pulled the tooth out, and that was intense. So I'm sitting in the chair and doing all of the things I know to do. Get your breathing right. 4 seconds in, 4 seconds out. You know, this is fine. It's just pain. Talking myself through it. And she looked at me and she said, you know what? I'm going to give you a prescription for opioids. And part of my brain was saying, please. And the other part was saying, ooh, I wonder what you're going to tell me. And she said this absolutely beautiful summary of, we have good evidence that 3 to 5 days of opioid use for acute pain can help you to recover in a way that you're not going to end up in a persistent pain state, because we want to avoid that. What we want to do is tackle this quickly and hard and get it done. You're going to take all of this that I give you for 5 days. It tapers you off, and then you're going to use Tylenol if you still need it, and you'll be fine. And it was fabulous because that's what we should do. That's an appropriate use of opioids so that someone does not have to suffer. There's no reason to do that. And prolonged use of opioids sensitizes the nervous system, and we want to avoid it. We want to make sure that we're not doing that. So there is proper limited use. And that's a challenging thing in what you'll see in the internet, social media, of people talking about opioids like there's some sort of horrible thing that we should not be using. That's just not true. We just have to use it in a proper, limited way. So that's great. We do 5 days, and then we come off it. And what now? What if the pain's still there? What if it's persisting? What if we're off the opioids, still a little bit of pain? What do we do? This is my it's not really a trademarked thing, but conveniently, we know that meditation, some sort of purposefully calming, constructive rest kind of way to build that into your day, where every day you take 10 to 20 minutes to calm down, to breathe, to relax, to think of things that are helpful for you, to really just bring your autonomic nervous system down is a good thing to do. We also know that mindfulness, being aware of what's going on in your environment, how you interact with your environment, what are your triggers for a pain state, we know those things are also very helpful. CBT or ACT, those can be great tools to help someone negotiate some pain that lingers. We know from some really good evidence around back pain and pretty much all musculoskeletal pain that movement is the thing that is good for us. That if we can get at least a half an hour every day of aerobic activity or strength training or something that challenges our system and keeps it robust, that's really helpful and preventative for our nervous system. We know that there is some limited use for modalities, that feeling good can make us feel good enough to move. And that can be the difference between someone who can get the movement or who doesn't feel like movement is safe, or perhaps movement safe, but once you start doing it, you're going to need to do something to recover from it. That can be really helpful. All of these things are part of what we do to move along, to keep going in the challenge of dealing with persistent pain. And we also know to mix it up and to find some joy, to put some pleasure into the system. That's also important. Sometimes, as is what is happening right now in the background, if you can hear it, there are sirens that tell you that things might be happening. Chicago can be noisy, and I apologize for that. Sometimes people end up in still uncontrolled pain. They've done those things. They've done them maybe 2 or 3 or 4 times. While we know that pain can change and that there is no expiration date after such a date, some person is stuck, however we are, we know that's not true. Pain continues to change. We continue to be able to modulate it. All of those tools remain available to us forever as long as we are alive. And some people have pain that is not well controlled, and they have tried all the things, all of them, sometimes twice, with the best people they can find, with all of the options and opportunities, and trying over and over again and being told that they'd be fine if they just did these things over and over again, and they still hurt. It happens. It's true. And these people are sometimes not believed. They've been telling people that they're in pain and trying all the things, and they're still fighting to try and find something to help them. The amazing Bronnie Thompson she's at Pain Skills online, and has spoken with the San Diego Pain Summit a few times. She's fabulous. She makes a point about it's important to give the people who show up for therapy credit for showing up, for despite how much pain they're in, to continue to get dressed, get outside, get to the clinic, try one more time with one more person to try and make something happen so that they can be engaged in a meaningful life. These people are persistent and they can still remain in pain. And our job is to try and help them. It's really helpful if what we can do is to not make it worse, because the words that are used in healthcare can be brutal. They can make everything worse. These are information topics that have come from patients that have told me what they have gone through over the years. And it hurts them to be told that they're in unrelenting pain, and the doctor or the insurance company feels like they're just looking for drugs. Which, if you're in unrelenting pain and you're trying to find a way to not be in unrelenting pain, drugs are something that might be reasonable for you. That doesn't mean you're looking for drugs to go sell them on the corner. It means you are looking for something to be able to get up and take care of your kids, to be able to engage in work so that you can get paid, so you can pay rent, so that you can do something you love. Because the literature says if we do something we love every day, we're going to be better. But if we hurt so much, we can't do that. You get kind of stuck in the middle, and there needs to be something to help bridge that gap. And then there are people who say that, well, if you're looking for drugs like this, then you're just an addict. And they miss the difference between need and addiction, where they would really very much like to not be in pain. They're not doing it for a recreational sport, not seeking medication for recreation. They're seeking medication because they cannot function without it. There's a consistent lack of compassion in what patients hear. I don't think that that's what the providers are trying to say, but that is what patients hear. Also, they hear that they're just exaggerating, that if they didn't, if they weren't drug seeking, then they wouldn't be making it such a big deal. There's that, or thoughts that they're saying these things to get some kind of secondary gain, to sue someone or to have workman's compensation pay them, or something other than trying to be able to negotiate into a meaningful life. Some people feel like if you hurt, it just means you're not trying hard enough, that you're weak-willed somehow, that you're less than, just not trying hard enough, just buck it up and keep going. Or the very dismissive, it's all in your head, like we hear with pain in general. They should just try harder. And one of my patients told me that one of the hardest things for them to hear is when a physician says, there's just nothing I can do for you. And they are there off of medication because they have been taken off of it. And there is nothing offered to them. So they could work, they had been working, they had been interacting with their family, they were taken off the medication, and now they hurt so much they can't. So then what do you do? Well, then they're told just learn to live with it. Those are hard words to hear, and they are anti-helpful, I believe. Forced tapers are called that because the person did not ask to be taken off of opioids. They were feeling like what they were doing was allowing them to be involved and integrated into their life. And somebody decided that it was a really good idea to get people off of opioids because of what we know about them sensitizing the system. So you can see where I'm going with this. There's a challenge. There's the physiological knowledge from a science perspective that it's good to get people off of this, and we need to have alternative ways to help with people through movement, through exercise, and mindfulness, and fabulous programs that exist for the people who are starting to have pain now. But what we are grossly failing with is, what do we do with the people who were already on opioids and managing their pain with that and are taken off of them? Then what happens? Where did they go? What happens when the mindfulness and movement and meditation and modalities aren't working? Then what? And I went on a 6-month rabbit hole down the internet in different pain and patient-oriented societies to find out what's going on, to try and fill this gap. And inspired by a patient that I'm going to talk about a little bit later. And it's there is a need. There are government policies that are designed to try and stop the opioid addiction and the very honest negative effects of prolonged opioid use. There are organizational regulations that are in like hospital systems or through insurances that can stop providers from prescribing opioids. There is a general mistaking of dependence for addiction, where people are thought to be drug seeking because they're addicted, but what they are instead doing is using the medication because it helps them to function in their life. And I know that's a very fine hair to split, but for people that don't think that they're addicts and all of the connotations that come along with that, they're just trying to be able to still take care of their kids or still take care of themselves or work so that they can pay rent or their mortgage. These are people who are trying really hard to keep their lives together. And there is also in some cultures, a negative societal association with pain or disability as a weakness, a less than, and people will take that on themselves, which doesn't help, or they're seeing health providers that do that, and that doesn't help. It gets really messy. The government policies that we have in the U.S., we have the Centers for Disease Control guidelines that have been out for 10, 15 years now and are continually updated. They recommend consistently a limited use for non-cancer pain. That's the 3 to 5 days for acute pain and then wean them off. And they want to get people off of opioids, to get opioids out of the community. They are looking at reducing community availability, because one of the problems, and it is a very real problem, of opioid use in the community for people who are not dealing with persistent pain, where it's sold and people use it as a way to get high, or to deal with stress or a lot of other reasons, and it ends up with overdose or suicide or other negative societal and personal consequences. So this is real. It's a very big deal. There's a push recently, like in the last month, to really get more limited prescription filling. And from an organizational standpoint, that makes sense, because then there would be less available in medicine cabinets for someone that isn't taking it to go and find the opioids and go sell it on the street for some money. Funny story, because we need to laugh about this sometimes. I live in Chicago, and there was before the COVID times, I had come off the train and was walking to a friend's house, and I walked past two old guys, and by old I mean in their 70s, maybe 80s, that were standing by the train in this very nice neighborhood, talking about what drugs they could sell to other people that needed them. They were raiding their medicine cabinets to sell stuff to people, knowing that they could make a little bit of extra cash. And like, okay, entrepreneurial spirit, also wrong. And I remember that because I think of it as a way to counteract the preconceived notions about who's out there on the street selling their drugs. Apparently, a wider variety of people than you might have thought. So I understand the logistics of why you might want to partially fill a prescription. But I think we also need to recognize that for the person who has a really hard time getting to the pharmacy because they may not have a car, or it might be too far away, or it's only open when they're working, or just for whatever reason, that partially filling a prescription might put more barriers in place for people who legitimately need these medications than are getting it. So going out of the US, and I apologize for our international friends, I am in America, and this is a very America healthcare centered discussion. The National Health Services in England just proposed some guidelines in 2020, and their recommendation was not to give opioids at all. Like, we're just done with them. We're not going to use them. It's still a recommendation, and it's open for commentary from a select group of people, but the patient groups online and social media and in forums are exceptionally displeased with this, because they feel like they're being purposefully left out, treated like some addict instead of someone who needs the pain for legitimate, or the pain control for legitimate reasons. So this is a ongoing challenge even today. That's the federal regulations, the structural regulations within a company. But then we get into a smaller focus where you're looking at organizational regulations. And that is where we start to talk about what's happening on a local basis. The data for this is really hard to find. It's internal. It's what a particular hospital system is doing, or a group of physicians is doing, or like my dentist is doing, of how they're following their guidelines and who is overseeing them. So these are for prescribing professionals, and it is often internal. It also has a third-party payer component to it of what's going to get covered. The doctors need to justify their opioid prescription, and they are watched. It is tracked. It's tracked federally in the US, it's tracked in organizations in the US, it's tracked through pharmacological organizations. There are a lot of layers where it's being tracked of who's prescribing opioids and how often and to whom. Patients are tagged if they doctor shop for medications, so that they might be told that I can't help you anymore, there's nothing I can do for you. And then the person's like, well, this is unacceptable. I need to find someone who can get me some fentanyl so I can keep working. And they go find another physician, and it pops up in the system that they were denied somewhere else, and now they're drug seeking. And I do the air quotes on purpose, because from a patient perspective, that is telling them that they're supposed to just live with their pain, and the medication that they thought was helping them, that has been forcibly removed from them, is now being put in a position where if they try and find it, if they try and be creative and find ways to get more, that they're some nefarious person who has illegitimate reasons for wanting it. And as one of my patients said, she was told, this is her quote, "I know you're in pain. I'm not allowed to give you more prescriptions. There's nothing I can do for you." The difference for this person was the ability to go to work, to make a paycheck, to pay for a place to live for her and her children, or not. And so it's hard. It's really super hard, because we know we want to keep opioids minimized. We know that they're not helpful in the long run, but there's this whole group of people that have been on it and functioning, sort of, that are left in this middle place where the people coming on with acute pain, like me after the dentist, aren't going to get put on long-term opioids. People with back pain now, they're not put on long-term opioids, but we have not grandfathered in the people that were already on them. That are now being told, we're going to take you off them, we're force tapering you, and that's it. So it's important for us as healthcare professionals to have these hard conversations of what's happening to our patients when they have uncontrolled pain, when even though the opioids may have been only partially controlling their pain, or maybe placebo controlling their pain, but they were functional. They could do what they wanted to do. They had meaningful lives. And that's been taken from them. We see higher incidences of depression, which is ironic, because everything I'm going to say on this slide is also just recently came out in a paper that is hotly contested from the patient perspective, about how opioids are strongly linked to depression and suicide. The patient view on that is being forcibly tapered off your opioids is also strongly linked to depression and suicide. So this is a timely conversation. But depression, pain hurts. And being in persistent pain when you can't find a way out of it is depressing. It's also incredibly isolating. And we know that when we're isolated and we can't be involved in meaningful activities, that is also depressing. It creates a financial distress, because if you can't do the things that you would need to do, someone else is going to have to do them. You have to pay for someone to put your air conditioner in, because you cannot lift it on your own because you hurt too much to even do it. And you know that after you do that, you're going to pay for it for days, and you don't have any breakthrough pain medication because they took that away from you. So there's more money outlet. There is people who can't work now. What are you going to do with that? And then it goes from just financial distress to poverty. And then the thing that gets me the most, which is why I said bring a tissue, is that then you get people that are like, why should I stay? If this is what life is, why do I stay in this life? And I don't even want to count the number of times that patients have told me that. When they come in and they're like, I am in unrelenting pain. They won't give me any more medication. I can't get pain medication. The doctors won't give me anything. They tell me that I'm just an addict, and I can't work because I hurt too much. And I'm trying to figure out a way from this, and I've done all my meditating, and I'm doing exercises every day. Their program looks fabulous. They're eating really well. They hurt. And there have been people that have said, I have a date picked, and if I'm not better by this date, then I'm just going to stop this. And that's real. It happens. These are people that are affected by this. They are stuck in that gap between, we know opioids aren't good long term. We know that they sensitize the nervous system. We know that part of this pain that this person is in is because they have gotten sensitized from the opioids, and they need a better program. And we need to help get them to a place where they can be okay with that. But they are very much not okay. And we see them in that gap where they are very much not okay. So here's my take a moment, take a breath, because this is hard. This is like, oof, you got into healthcare because you want to help people. And sometimes people come in and they are in a hard place, and they might come in one after the other on the same day and be in a hard place. And you need a minute in between them or at the end of your day to just take a breath. So we know this exists. We know that it's hard. And what we're going to try and do is to say, well, what can we do about it? What do we do? And I want to wring your souls just a little bit more with this conversation, and give you an insight into a person that has been dealing with this. This is where I'm going to be doing this. So the glasses check is because I have to get my eyes. So I had a healthy young person, very healthy, very active, lots of friends, lots of family around, one of those picture perfect lives, had a boat in the local harbor and was part of the boat clubs, and races, and really involved, doing all the things that made them happy and they felt good. They decided that what would make their life even better was to go to rabbinic school so they could get deeper into their faith and then share that with others and help people find joy in all sorts of different ways. All was going really well until they developed migraines, really bad migraines that weren't going away, and they got put on more medication at school, but it made so that they couldn't really focus, and it was very hard to be part of any course. They had to come home. They came home and they got put on more medication, and that dulled the thought process more and made it harder to get involved in things. They started withdrawing a little bit, so they got put on more medication to try and balance that out, but it was unhelpful. And then because they stopped moving like they normally did, their back started to hurt. They ended up with some injections and some other medication and some muscle relaxants. And now they not only couldn't go back to school, they also couldn't work. And they couldn't afford the fees anymore for the club, so that they lost that connection. They lost connection with school. They lost connection with the sailing buddies. They lost connection with family that thought that they were just exaggerating this, making this up, trying harder than they needed to be. And friends sort of moved on. They were still in pain. And it had been years now, 10 years now, from migraines to back pain to an inability to do the things that they enjoyed in their life. And then Congress here in the US decided that we have this opioid epidemic, so that the doctors in the institution said, you know what, we are no longer allowed to give opioids, so we're going to force taper you off, and we have no more medication for you. And that was it. That was all they were given. They'd literally lost everything. Friends, family, job, hobbies, the things that made them feel happy. Old enough now to be on Medicare, so can come for therapy a certain number of visits every year to try and maintain, but completely on their own and financially absolutely strapped. And the answer, when you talk to other physicians, is, well, my hands are tied. I have nothing to give them. And that's where this person is still today. Actually, they had an orthopedic challenge that qualified for a procedure that qualified for some acute opioid um, prescription. So the person is using the minimal amount they can possibly get away with to try and save it and stretch it into the future, because they know there's nothing forward from that. So what do we do? Where do we go from here? This really isn't all just doom and gloom and sadness, although we do need to acknowledge that this is a really hard situation for people. There are solutions, I promise you. The American Medical Association is gathering information on people who've been stuck in this gap. They know that it's happening. We know that there are logistic, local, and federal problems for achieving care. We know that that's a problem. They can intervene, like reach out and tell a doc to give them medication. They can't give them medication themselves, but they can create a change. They can try and change this at a federal level. The patients need to reach out to them directly. So if you have people that are in this, they need to get a hold of the AMA. They need to find out how they can share with them their information, and just call them directly and tell them what's going on, because they're collecting that data. The other solutions is that there are individual physicians who recognize this as a problem, who do have prescribing authorization. They can provide medication for as long as possible within their organization. They're working with patients individually. This is so unique because it depends on where the patient is. If there's a physician that can do it, that is allowed to do it. Doctors are stuck in a place here as well. This does not exist because physicians have said, I don't care about you. This is all of these complex problems that are involved in it. It's challenging or hard or impossible to change physicians in order to find someone, because then you'll be possibly identified as someone who is drug seeking, but persist, because there is hope. And we as clinicians might be the people who have to speak up for our patients, to intervene with their physicians, to say, look, they are doing all the things. They've done all the things 4 different times in every way we can think of. They need something to help them be able to do this. It's not an acute situation. They've been stuck in the gap. And how do we help them to get them out of it? So you might need to be the person who speaks up for that. It's also necessary to remember, just like with pain treatment, that there's no one intuitive or easy answer to this. There's no one pharmacological option for someone. We just have to acknowledge that there are people stuck in between and they need help. And remember that pain can and does change. So even though this is super, super hard for them, and we wish we could go back in time and get them off their opioids after 5 days and onto something else, they are not there. But we can meet them where they are and help them design a program and help be solutions for them, so that they don't feel so alone. So we can turn them around on that road and help them move forward. And I do honestly believe that there is hope, that this is hard. It's really excruciatingly hard in all kinds of different levels, but there is hope. We have community resources. You might be the only one helping them find the resources. So get to know your people. The social workers can be super helpful with this. Independent medical doctors, and that I say that to mean outside of hospital organizations, because sometimes while the physician in the organization might be really wanting to help, they have some restrictions of what they're available to do because their prescribing habits are monitored. The American Medical Association, like I told you, if we can get people to contact them and let them know that they're going through this, it's like the Horton Hears a Who. If we get enough people telling them that, look, real people are being affected by these policies that are not flexible, and we need to speak up for them. They might need to contact their congressional representatives. They might have to really reach up the chain for this to get some attention. But I do want to let you know, as a clinician, there's a word of caution here. Be careful with what groups you're dealing with, because some of them claim to be helping patients, but They aren't. There's a group, the Physicians for Responsible Opioid Prescription, which sounds on its face like it's great. They lobby Congress to eliminate or severely restrict access for non-cancer pains. That's like what they're trying to do, is let's just get rid of opioids, much like what you see in England with the recommendation if we're just going to get rid of opioids, which is great, except for what about the people who are already in pain? There's no grandfather clause. There's no plan for those with uncontrolled pain when they're forced tapered off their opioids. The people who are dealing with chronic pain on social media do not trust this group at all. And one thing to remember for you as a clinician is if you're going to go down this path and work with people with uncontrolled pain, you need to find some sort of counselor. You need to find someone that you can talk to as a clinician, because you're going to hear stories of extreme loss, and you will hear plans of suicide, and you're going to need a plan to recharge your batteries and take care of yourself. Because burnout is real, and you need to find a buddy. You can't be of help to someone if you use yourself up trying to help them. So balance in all things. And the non-negotiable self-care for you and your patients is that you need to do daily exercise. You have to sleep 7 to 8 hours a night. Do whatever you can to make that happen. Eat good food. I'm not going to tell you what kind of food to eat. There's plenty of people who can do nutrition for the best health for bodies. Do that, but also have it be food that you love, because things that we enjoy in our life can help mitigate the challenge. Please remember to drink water. It's really important for us. Limit your alcohol. I know it's fabulous and fun, but if it's just a little bit, then it can be fabulous and fun instead of something that actually is like expensive, sad juice that just makes everything harder. Purposefully work to see the beauty around you, to look every day for stuff that is pleasurable and that you can engage and interact with. And then find the good in others, because it can be really easy as this challenge of helping people and the challenge of refilling your batteries to get a little bit grumpy. Please look for the good in other people and work your to-do list wisely. No one's going to come and steal it from you. It'll be there when you get to it. You need to make sure you take time for yourself. So I do think that there is stuff that we can do. I see I'm still a little weepy. Sorry, Rajam. I tried 7 times to record this. These are real people that really need help. The gap is real, but we can have all these different ways that we can help people to pull them out of that gap and help them to find a way to manage and mitigate their pain, even though they got stuck in that place where they weren't taken off the opioids fast enough, and we still have to help them. So there are fabulous programs out there. There are a lot of really good people trying to help. You can find me on Twitter, Sandy Hilton PT, or on email, and I will have Rajam put all of my information on those fabulous contacts. Find me at the fire pits or the pond, and I'll tell you more if you're interested, and bring a Kleenex because the stories are rough. Thank you for listening.
Oof.
How you doing?
I'm good.
Great job.
Thanks.
This is my first nighttime conference with glasses, so all I see is my reflection. Better?
That's good. I feel like I'm back in school and you're looking at me like this.
I am. Okay, so we have some questions, some comments, and also some personal experience. So this is it's kind of a long one, so I'm going to kind of put them up as I read them, and then you can let me know if we need to put them back up, because I can only put one up at a time. So I am in the UK, and I was put on opioids and left on them for 13 years with ever-increasing dose. My life deteriorated horrifically. How do we ensure that the opioid crisis that you have in the US doesn't happen here? How do we encourage doctors to use only for acute pain or short spells and not for chronic pain? It's easier to prescribe. It's kind of a similar issue to here in the United States, as there's not much time together. But the opioids manipulated my brain into making me believe and argue that I needed them in order to survive.
It's hard. Oh, one, I hope you're doing well now. And there are, like I said in the presentation, there is, I don't remember the exact reference where it came from, but there is in the UK some discussion about what to do to limit the opioids. There is a lot of awareness in groups like the European Pain Federation and IASP for sure are very, very mindful of what's being said and what's being taught, what's being promoted at conferences about opioid prescription. So I'm confident to say that the whole world is paying attention to this. And honestly, I think some people are right to look at the US to say, we're not doing that. So hopefully they'll learn from our mistakes sooner than later. But I would say get a hold of like the European Pain Federation or the British Pain Society would probably have the most up-to-date information about what's happening there.
Awesome. Hi again. In my case, there was visible evidence of harm from the opioids. Some people don't have evidence of harm, so should they be allowed to continue? There's a second part. Hold on. I was told I couldn't because I became addicted, dependent because I was taking it for pain. I'm so sorry. I was told I couldn't become addicted or dependent because I was taking it for pain. It's on OxyContin and Oromorph and codeine, et cetera, et cetera. I can't imagine how the people in the US feel or cope and facing forced tapers.
Yeah, I just like, it sucks is my summary for that. My disclaimer of not being a pharmacist or a physician. So if I get this wrong and someone is listening that is that, I apologize. It's just not true that you can't get addicted to something just because you're taking it for pain, but different people have different responses to it. There's a term I heard from one of the addiction centers here in Chicago about accidental addicts, where you get really confused between different instructions from different providers and being in pain and then being fuzzy from the medication or all of the different side effects, and people can end up taking more than they're supposed to and it messes it up, or not taking enough and it messes it up. So the whole how to titrate the medication to an individual really needs to be individual and worked with providers that know how to do that. I think we know a lot more about how not to make mistakes than what to do when a mistake has been made and how to help someone out of it, which is sad. But there is something that I found out just this last week. Time is a little fuzzy these days, but I think it was this week that I had mentioned about the AMA keeping information on this, and apparently something is going to be moving forward where for specific patients in the US with specific physicians, they'll be able to get back on opioids for a short term with some better coverage while they try and find out what else can be used for them. So there's some movement towards a middle road with being able to cover the pain reasonably and responsibly while looking for another solution, instead of that just boom, you're off. Yeah, it's not good.
Okay. It's all hard, right? Okay, so now this one is, again, we have a character limit for how much can show up in each one. So this is again a multi-part one. How was the experience of being able to talk about this topic without the social pressure of being in front of others? Did you feel that as enabling you to connect with the talk, or did you feel isolated, not having feedback? What was it like to have the freedom to cry? I noticed the colors of people of color in the presentation. Curious, was that a choice as an inclusivity of that population to this topic, or passive reminder this is a community which is impacted significantly with difficult access to healthcare, along with disregard by the system thus inadequately served. Let's
Can I go backwards? Is that the end of it? Thoughts on?
It looks like there's a second part, but let's just take the
Okay. I'm gonna go backwards from this. I chose the pictures on purpose to have them not just be a bunch of white guys. So it is different on purpose, and there are certainly disparities in how people have access to care and what kind of care they get when they do have access. And Deborah's talk on this was fabulous, of assumptions that are made based on where they live or what color their skin is or anything. But I chose the pictures on purpose to just not be the same. Was it easier without? I think it's easier when there's people in front of me because I can distract myself by looking at people instead of just staring at the little green dot in my words and being alone with my feelings. So no, that was hard. I think that's why it took me so many times to try and record it. Yeah.
Okay. Let me find the number 2. Okay, so here, thoughts on pharmacies gatekeeping gabapentin as a Schedule II drug when it is not, again, making access difficult.
Yeah, that stuff is weird. So many of the things, especially, and I only know to talk about the US, so many of the things about why a drug is a schedule whatever seems to be more political than rational at times. Some things that are perfectly safe and have been around forever technically could be over the counter, but then they put some medications that were over the counter back and you need a prescription for them again, depending on who's seeing use and if they think people are selling them, using them to make something else, or taking them irresponsibly.
Okay. So sorry, I just need to figure out where we are. All of these are great comments and thoughts, but also it's very hard to keep track of them all. Okay. I'm not sure if this is a continuation. Okay. I would have argued black and blue that I was functioning perfectly on my high dose of opioids, but I wasn't. I could not see it through. So when people argue, how do we know their judgment is sound? I was fortunately persuaded that the opioids were harming me, but what happens if doctors can see harm but the patient cannot?
That's a really good question. I'm going to go from what patients have told me of like a couple that I was talking about in my presentation. They got it, that opioids sensitize and that it was not a good idea to have done years ago. And yet here they were. Their argument really wasn't so much, I want to stay on my opioids forever. It was, fabulous, take me off it, but you have nothing that's controlling my pain. So I think what needs to happen is a better education, a better discussion, maybe taking more time with people when you talk to them about why you're going to take them off of opioids and what possibilities are there, instead of what has been so harsh of you're off, or you get, I'm only going to refill this one more time. But then there's nothing to replace it. And I know that there are some people who have been taken off their opioids, have a really rough adjustment period and do well. And those aren't who I'm talking about. So it's what if it's not working? So they, like the person that used to say all the time, they know that opioids aren't good for them. Quite happy to never take them again. But they hurt too bad to do anything. So they're kind of stuck. So I think probably the best answer to that conversation is we need to talk to people better. And us as clinicians can be the people who do that. So maybe the doc said it, you know how that goes. Like I know, because I've worked with orthopedic patients, that they'll have a total knee replacement and they'll come in 2 years later and say, they told me I could never kneel again. I know that's not what the surgeon said. And I know they don't say that, but that's what the person heard. so sometimes maybe someone will come in and say, the doc told me this, and we could take the time to unpick it a little bit or talk to the doctor and find out what they said and maybe be that link for better communication and less stress. Yeah.
Okay. Awesome. Thank you. Okay. Here is another long one. I had a surgery, tonsillectomy, last year and wasn't given anything afterwards for the pain, which was very high, other than Tylenol and ibuprofen, alternating specific doses of that. My doctor said the opioids wouldn't be any better for my pain than those. After 4 days of severe pain and the doctor taking all day to get back to me, he still refused to give me anything to help with the pain, and said I could get an anti-inflammatory shot at the hospital if I absolutely needed. When I went to the ER, they said I could up my ibuprofen and Tylenol and that the shot wouldn't be any more beneficial. Here we go. Then just increasing those doses. I had a very long conversation with my surgeon about my negative experience and not feeling validated, listened to, taken care of, or any other or given any other ideas to help with the severe pain that lasted for 10 days. I tried meditation, movement, mindfulness, self-massage, which didn't even touch the pain, made it worse because it failed and didn't help. And I do not see the end of that. So.
Oh man, this is like leaving me hanging. Oh.
Wait, hold on. I might have it. Hold on.
It's showing.
Oh.
Are there is that it?
I think so.
Okay. He's going to use he has more ideas on how to talk to the patient. I would love to know your talk with him. I bet that was fabulous. See, we know this is where I get frustrated because like my dentist did, that was really good. That hurt a lot. And Tylenol wouldn't have, I had to just know. I didn't even drive myself home. That's how bad it hurt. Sarah knows that scale level. I didn't try and do it myself. I can't even imagine that. So what she told me was great. And that's what the science says. So I don't know, I could look. I feel like that's all very old. The Brain Man video talks about that they're really good for 3 to 5 days and then you taper off of them. I don't know why people have gotten so scared to use them short term, because that is what they're for. They've gotten kind of demonized, which is sad. And like saying we're never going to use opioids, we're going to get them off, it's just going to make people hurt more, which could sensitize them to pain, which is a really bad idea. So that doesn't make any sense at all. But I will, if you find me at the fire pit and tell me who you are, I will see what I can find.
Okay, and I think what might be our last question for this session, can you give an example of the patient deference charting versus typical regarding your last comment?
What did I say? Which last comment? The last comment in my presentation or something I said here?
I think in the presentation.
That's awkward. Help me out, Sarah. What was I talking about?
So we just had some help from the backstage crew that says just from a long time ago.
Oh, when I was talking about, thank you, from a long time ago, in a galaxy far, far away. Maybe what I was talking about was that some patients respond well and some don't to opioids. Like some will.
I hope I'm doing this from an earlier question.
Yeah. I don't know what it was.
Well, we have 2 minutes, and I think all the questions have been answered.
Sorry.
Let me see here. Yeah, I think we got everything.
Because I don't think I think of the patient deference. If it could be that some people, the comment from the person who had been in pain for so long and opioids definitely made them worse. And that some people do get addicted to opioids even though they're taking them for pain, and some people don't. And some people will you know, it's just like some people come off. It depends of orthos, as we don't have we don't have a way to predict how someone's going to respond to opioids. We don't have a way to predict how they're going to come off opioids. And I hope that answers your question, because I have no idea what I said earlier. That's normal. That's not even like because it's late.
And if you happen to be coming to backstage, you can definitely be part of the discussion. If not, you can head over to the fire pit in Gamer Drive, or we will see you tomorrow morning. What was that?
Find me tomorrow.
She'll be around tomorrow. And we will start off tomorrow morning bright and early, 4:30 a.m. Pacific time, or 6:30 a.m. Chicago time.
7:30 Eastern.
7:30 Eastern. Yeah, so another great day of things tomorrow. Those of you who have backstage passes, I'm going to open up the Zoom meeting in a minute, and I think you'll know in 2 minutes because there's a lag, and we will see you there. And if we don't see you there, we will see you in the morning.